You have, Danielle?
Yeah, it's snowing now, and there's like it's pretty much covered, like the ground is covered, not a lot, but it's definitely coming down here. So,
Awesome. Same, Unel? Yeah, fun. Yeah, we have a little light dusting right now, but it's really the chill. When I was taking my pop out this morning, you can feel it, the wind chill and the coldness as we were going outside. Coming down hard in Southeast. Okay, Dylan, nice. I know my family, I have family in the Gorge in Cascade Locks and then I have family in Eugene. And I know Eugene actually got hit sooner with ice and snow. They had freezing rain, so the roads there are terrible. But their snow is pretty like a dusting. And then in the Gorge, haven't heard from my dad yet of what it's like in Cascade Locks, but I'm assuming cold. I don't think there's a lot of accumulation yet. But the winds were pretty crazy last night, like 80-mile-an-hour winds where he's at. So pretty wild stuff. All right. I'm going to close down your beautiful faces just so can see the screen, but feel free to like talk or raise your hand. I think those will pop up here. And if I'm missing something in the chat, I'll try to pause every once in a while and just check in and see if there's any questions that have popped into the chat as we go. So first, we're going to go into upper extremity. And so we're going to start with orienting ourselves to the spinal cord and some of the segmentation of the spinal cord. Will help us when we talk about nerve roots and nerve roots in relationship to different nerves throughout the body. So if we look at our three kind of segments here, C1 through C7 and as your cervical nerves, C8 is and relates to things, structures that are above. C8 is located, it comes out above T1. So I know this is like really tiny, but you can see C1 through C7 comes out above its vertebral region. C8 comes out above T1, thoracic vertebra 1. And then T1 through coccygeal comes out actually below the vertebra. And this is a helpful distinction because we need to know kind of those associations. If NPLEX asks questions about spinal compression, vertebral fracture, what nerve root could be affected, that's where these type of questions, or even if we had like a collapse or if we had narrowing of any space between vertebra, that's when these kind of questions could be asked. So again, C1 through C7 above their cervical vertebrae, they are so named after. C8 above T1, then T1 through coccygeal is coming out below the vertebral segment. All right. The cervical cord is one above, let me see here, one above the spinous process. Thoracic cord is two above its spinous process, and lumbar cord is four above the spinous process. What does that mean? That means that like where the nerve is actually, the track is actually tracking. So if you're palpating down your SPs, you palpated SP for cervical vertebra 4, you're going to know that the cervical cord is coming out one vertebra up one level above that, which makes sense if we think about where we feel the SP versus where the actual transverse processes are that oftentimes these nerve roots are running through or next to. So cervical cord 1, thoracic 2, lumbar 4. When we look at spinal segments, we can kind of see we do have these pairs of nerves, right? They're not just coming out on one side, they're coming out on both sides, right and left, and they're attached at these spinal segments. The spinal segments respond to the vertebral levels in every region except for cervical, again, because their cervical are coming out above. Looking closer at then, okay, our spinal cord and peripheral nerves and kind of all these structures that are coming out here. We're going to make some definitions. We're going to define some structures for us today. So rootlets, anything that's called a rootlet is extending out from the dorsal and the ventral horns and are converging into roots. So rootlet, so if we look at our spinal cord here, we can see that we're looking at dorsal side here, ventral side here to kind of orient ourselves. We can see those arrows associating. And so we have our rootlets that are coming off the spinal cord and they're converging into the root. So our rootlets, our ventral rootlets converging into our ventral root, our dorsal rootlets converging into our dorsal root, okay? Then the dorsal and ventral roots are gonna exit our vertebral column and unite. So that we see where they unite here. So this one went this way, boop, and this one went this way, boop, and they're uniting into one. And once they unite, we call that the spinal nerve, right? Then our spinal nerve will split into rami. And I don't know, this side we can't see it, but this side we can. So we'll kind of switch over to this side here. We can see our dorsal rami here and our ventral rami here. All right, so it's split now. This was spinal nerve, dorsal rami off, ventral rami off. The dorsal rami or dorsal ramus is innervating our deep back muscles and skin. Our ventral rami is innervating the remaining muscle of the body, skin, et cetera, et cetera, et cetera. So that's how these kind of spinal roots or spinal nerves are splitting off into different sections. The majority of nerves that we then are encountering are coming off our ventral rami. So when in doubt, that's a great place to say, that's a great question to ask. Ventral rami would be a good guess if you don't know for sure. And in the upper extremity, our ventral rami are forming our brachial plexus. So that's kind of some important pieces. We can also see here the relationship to our autonomic nervous system. We have kind of these communicating rami here, these structures communicating to our sympathetic trunk for our sympathetic nervous system. So that's kind of how we can tie that back into that sympathetic chain ganglia right next to our spinal cord. Okay. We'll talk more about our nervous system later on, but this is important for understanding innervation of the upper extremity. So we can divide our upper extremity into kind of two different sections, the brachium and the antebrachium. And if we're thinking about first bony structures, we look at our pectoral girdle and bones of the upper limb from the superior appendicular skeleton. It's going to articulate with our axial skeleton only at the sternoclavicular joint. So at the we can't even see that here, which will give this kind of region, this whole appendicular skeleton, a lot of mobility because it's not tied down to that axial skeleton. And all of the muscles that make up this appendage, essentially our upper extremity, are going to help to support that pectoral girdle. We think about our rib cage and all of the different kind of supportive muscles that are going to connect from this region and then also support our axial skeleton. If you're not sure about the bones, like these are your bones that you can follow along with, but I'm not going to go too much into bones here because I think those are the easier basics. So then looking at our favorite structure, our brachial plexus. Let me see if I can move this out of the way. I don't know if I can. Brachial plexus there. All you got was the title. So when you're looking at our brachial plexus, remember, this is coming from our ventral rami. And we are then seeing these like nerves that start things out. The purple here is showing the nerve roots and what they're actually going to innervate at kind of their end points. So C5, that nerve C5 coming off of our cervical nerve root 5, which is going to come out above our cervical or our fifth cervical vertebra. It's going to innervate in the shoulder region, C6, our elbow, C7, wrist region, and then C8 and T1 hand. That's kind of our general idea. From there, we'll see that we will have some branching off of specific nerves. And there's more branching here than what's shown in this picture. But this is the minimum of what I would kind of try to put in your brain is this image here. This would be a great drawing out activity if you have paper. So I would start this slide and utilize this as a study point to draw out your brachial plexus. So with our nerves here, C5 plus C6 is going to join together to make our first trunk. C7 stands alone and creates our second trunk. And C8 and T1 are going to join together to make our third trunk. So we have our three trunk regions here. What has come off so far is our dorsal scapular and our long thoracic nerve. Dorsal scapular coming from C5, long thoracic coming from C5 through C7. How NPLEX often likes to ask questions is if C6 was affected, compressed, cut, damaged, what would be affected or what structures would be affected? And they could potentially give you nerves, muscles, regions of the body, movements, etc. So having that relationship with where these structures actually lead to first, then you can make those next level steps and say what would be affected down the road if a structure was cut or damaged. From here, we have our divisions. We can see that our trunk is going to split into two divisions again. These are our inferior and superior divisions or anterior and posterior divisions, depending on the text that you read. You can see that they're all splitting into our two different divisions. So the trunk split into two, and then that's going to form into two cords as we move further down kind of in this process. So we're kind of in this region now. Our chords are going to combine divisions from the different trunks. So we see our chord up top here is taking a division from C5 and C7, or C5 plus C6 and C7. We can see our chord here is taking a division from C5 and C7. And then we see our chord here is just dealing with its divisions from our C8 and T1. It's kind of the cheese stands alone. These are all the nerves that are coming off. And then we finally have our end branches, our musculocutaneous, our axillary is here, and then our radial, our median, and our ulnar. If you're looking at this and it's like, I don't have the brain capacity to commit this to memory, focus on branches and nerves to start. Know where the nerve branches came from. Be able to track, okay, the musculocutaneous, if we had to track it all the way back up, I'm gonna erase. Obviously, if you can memorize this whole thing, great. But the minimum would be to be able to track these individual nerves. So let's do ulnar. So we can track our ulnar nerve here. We can see that if we follow it up, we're going to get branches from our C8 and our T1 nerve roots. So then track it all the way back down. So that's our ulnar nerve. If we had an issue with C8 or T1 nerve root, it's going to affect the ulnar nerve, right? So, or vice versa. Now our median nerve, we can track it. It's going to be follow the same track as our ulnar. So it joins up here. So we have C8, we have T1, but then it also has this track here that's following along, C7, and then this track here that's following along, C6 and C5. So the beauty of the median nerve is it gets all 5 nerve roots. Yay, gold star. And then our radial nerve, we can track back. We can follow it back here. And we're going to see a split to this side, C8 and T1. We'll see a split here, C7. And we'll see the split here, C6 and C5. So again, all 5 nerve roots. And then our musculocutaneous, last but not least, our musculocutaneous, we can track back all the way here, and it's just going to be your top 3, C5, C6, and C7 is going to be your musculocutaneous. So they get 3, and ulnar gets 2. This means that our radial and our median nerve, they have a lot of potential sources or sourcing to be able to still function, at least at the periphery. Unless if all of these are compressed, we're going to potentially see some sensation being able to be achieved. Our ulnar nerve and our musculocutaneous nerve are going to be much more sensitive to damage at their sources, because especially the ulnar nerve only has C8 and T1. And as we see, the ulnar nerve is often one that gets compressed, and we can see compression up top or even compression at the elbow where it runs around that medial epicondyle. Brachial plexus. This is probably the most high yield nerve grouping in the upper extremity. Our shoulder has 4 different joints: glenohumeral, sternoclavicular, amioclavicular, and scapulothoracic. The glenohumeral joint is your classic ball and socket example involving head of humerus, glenoid fossa of the scapula, and it has its capsule region is kind of thin and loose, noting the inferior part is going to be the weakest area because it does not have the rotator cuff muscles to support it. Some other important pieces would be like your different ligaments, your capsular ligaments, glenohumeral, coracohumeral, transverse humeral ligament, and coracoacromial ligament. They're telling you where they're located based on their name. So if you can follow their names and track their names, you can follow them on these structures. I would say this is less high yield than the brachial plexus, but it is more probably of the joints. It's one of the more important joints to pay a little bit of attention to because of all of the beautiful ligaments, and it's really your classic ball and socket example outside of the hip, which is the other. But this one has a lot of fun things that we can look at. Where I want us to pay more attention to is going to be the muscles that are supporting our rotator cuff and kind of this region. The acromioclavicular joint, we'll see is kind of, let me see if I can give you a great example. Here's our ligaments here, between our clavicle and our acromion, our little structure here. We can see acromion located here, bloop, and then clavicle located here. The acromioclavicular ligament is going to be your main player in this joint. It's going to strengthen things superiorly, but the majority of the strength comes from the coracoclavicular ligament, and it has two parts, a trapezoid and a conoid ligament. The conoid ligament's attached to our coracoid process here. And so this is the coracoclavicular ligament here. It has two portions that we can see. Arterial supply in this area is interesting because it's supplied by the suprascapular and the thoracoacromial arteries. And then the supraclavicular, lateral pectoral, and axillary nerves supply the joint specifically as well. So lots of innervation, lots of vascularity, three ligaments, or really two ligaments, one that has two sections to note. That's your kicker for your acromioclavicular joint. So looking at vessels, when we look at the vessels of the upper extremity, we can see there's two kind of big veins, the cephalic and basilic veins, and they're going to originate on our subq tissue on the dorsum of the hand. And they are from the dorsal venous network. Let me see if I can give you the image here. Yep, cephalic and basilic vein. This is our dorsal venous network. These are these two venous structures. So here and here. There's then perforating veins that form between superficial and deep to allow for that communication. Cephalic vein will move up and it'll go to our anterior elbow and communicates with our median cubital vein. This is our often venipuncture vein, so for blood draws. So that's why it's important to know this vein, where it's located right here. And so it's going to communicate with our cephalic vein. The cephalic vein will pass through our deltoid and pectoralis major muscles in our deltopectoral groove, and it'll enter into the clavicle pectoral or deltopectoral triangle, where it goes in the costochoroid membrane to join up with the axillary vein. So we can track this cephalic vein up through our median cubical vein all the way up into the axillary vein. That's going to be our track there for those venous structures. So those would be the three I would know. The basilic vein is gonna ascend on the medial side. It'll go into our brachial fascia, and it'll go superiorly and parallel to our brachial artery, draining in also to the axillary vein. So if we're gonna really just break down our venous structures, we could see basal and cephalic in the hand. We're gonna see that the basilic vein is gonna move all the way up and drain into the axillary vein up top. Our cephalic vein will join up to the cubital vein, the median cubital vein in the middle, and then it'll eventually drain into the axillary vein. Knowing at least these four veins in the upper extremity will serve you well. Obviously, you can see there's many more, but these four will provide a good base. And oftentimes we recall that our venous structures are going to travel in tandem with lymphatic structures. And then our venous structures are going to travel also close to arteries to be able to hijack some of those artery pulsations to move blood flow against gravity and then back into the heart. All right. That's our venous structure. Then looking again at more structures kind of up top here, we start to get into some of these supportive muscles. So pectoralis major, a big muscle. I'm not going to talk about origin and insertion because I think those are lower yield. I will talk about innervation and action. So our pectoralis muscle is going to flex, adduct, and medially rotate the humerus. So flexion is forward, adduction is bringing something inward, and medial rotation. So we could think about adduction, medial rotation, and flexion, that motion, or you could think about flexion and medial rotation, or you could think about adduction, bringing something back in and adding it back to the body. The nerve is going to be the medial and lateral pectoral nerves. This is a classic board question. So knowing that both of them, medial and lateral pectoral nerves, innervate the pectoralis muscle, or pectoralis major muscle. Okay, important piece here. Our pectoralis minor, on the other hand, our origin is going to be on ribs 3, 4, and 5. I've seen that asked before. Our medial pectoral nerve innervates the pectoralis minor. So again, we have medial and lateral for pectoralis major, just medial for pectoralis minor. Our action is protraction, depression, and medial rotation of scapula. So where this is acting on the humerus, our action, pectoralis major, this is acting on our scapula. Pectoralis minor, good differentiations. You really are using it to stabilize your scapula and like you're stretching forward to touch an object that's kind of out of reach. Okay. It does insert on the coracoid process, and it kind of forms this bridge underneath, and the neurovascular bundle will travel beneath it. If your pectoralis minor then gets inflamed, irritated, hypertonic, it could compress that neurovascular bundle, and you could see things like numbness and tingling or impingement syndrome. Subclavius isn't really super a lot of claim to fame outside of the fact that it's the nerve to the subclavius is its nerve, and its goal is to really stabilize our clavicle, and it does provide a little bit of protection against a neurovascular bundle if the clavicle gets broken. So those are really the only two things I care about with the subclavius. Nerve to the subclavius is its innervation, dealing with clavicle stabilization, protects the neurovascular bundle. So what are some of these nerves? Pectoralis major and minor. So pectoralis major, lateral and medial pectoral nerves. Pectoralis minor, only the medial pectoral nerve. This is a classic boards question. Our next two muscles are our serratus anterior versus the serratus posterior. So this is our serratus anterior here versus serratus posterior, superior, serratus posterior, inferior muscle, kind of by our quadratus lumborum. So our serratus anterior is holding our scapula to the chest wall. It's stabilizing that scapula. So it's providing protraction, superior rotation of the scapula. But I just think about it as it's stabilizing, it's holding it in. And its insertion, it kind of lists here, which I don't care about as much as your insertion. It looks like a saw, hence its name. When we look at the nerve, it is our long thoracic nerve. That is the nerve that innervates it. Remember, that does break off of our brachial plexus. It's stabilizing the scapula wall, and it forms kind of the medial wall of our axilla. Our trapezius, this kind of long, large, big muscle, almost makes like a diamond shape or triangle. We can see the origin here. Sometimes the origin does get paid attention to because the superior nuchal line is the top, and it goes down on the spines of C7 to T12. So sometimes knowing that end point can be helpful. So superior nuchal line all the way down to the SP of T12 can be a helpful piece for orientation. Innervation by our accessory nerve, which is a cranial nerve. That's why we do our shoulder shrug to assess if that nerve is intact. So this is a good boards question because that is a cranial nerve. The posterior triangle is an interesting space. It's the space between our trapezius, our clavicle, and our SCM. So this triangular space here is the posterior triangle. And it's interesting because our brachial plexus and our axillary artery are passing in this space between our anterior and middle scalene muscles. And so we can see that if those muscles are engaged, if we're having to use those accessory muscles for extra work of breathing, or if they're hypertonic for whatever reason, or if these muscles are hypertonic and really tight, we can see compression of these structures. And so it's the brachial plexus, which is our nerve, big nerve source to our upper extremity, and the axillary artery, which we found that, or we will find that it's going to be one of our main arterial sources. And then the axillary artery is running also with the axillary vein, which is our venous structure. So looking at that cranial nerve, our accessory nerve, this is showing kind of an example of how it's coming off from that brain stem and innervating to these muscles. It innervates the trapezius and the sternocleidomastoid. It's going to come out of the base of the skull, out of the posterior triangle of the neck, and down the side of the neck to the trapezius. So this is going to be its two big innervation points. Our latissimus dorsi is kind of this big, like large branching muscle. We had a question about it on our practice exam yesterday. It originates from T6 to L5. I only mention this because boards lately has really loved asking questions about where things are in relationship to vertebra structures. The actions are extension, adduction, and medial rotation. So you could say like it's your chin-ups muscle. It's helping you actually perform a chin-up because you're extending, you're adducting, and you're medially rotating. It also could be putting your hand behind your back as well. And it's the thoracodorsal nerve that is innervating this muscle. Now looking a little bit at kind of some smaller muscles of the upper back, we can see we have our dorsal scapulae, I believe, right. Oh no, our levator scapulae. Sorry, I was excited about our nerve. Levator scapulae, our rhomboid minor and our rhomboid major. So our levator scapulae, we can find it here. It's going to be deep to our SCM, and it's going to flex the neck to one side. Bilaterally, it will extend the neck. So lateral neck flexion or neck extension. Our rhomboid minor is, we can see, located, this is our major, rhomboid minor right here. It's going to essentially move from our scapula to C7 and T1, and rhomboid major is going to be from here to here. It's going to be the SPs T2 to T5 to the scapula border. And the actions of both these muscles is to elevate, retract, and medially rotate the scapula. Those kind of our posture muscles. All of them are innervated by the dorsal scapular nerve. So levator scapula, rhomboid minor, rhomboid major, all innervated by dorsal scapular nerve. They all come off that side, that wall of the scapula here. So, and they're posterior. So that's how I remember dorsal scapular for these three muscles. Okay. So what are our nerves to the muscles of the superficial back? We talked about the dorsal scapular. We've mentioned the accessory. We're going to look at the axillary and the suprascapular as well. So we can see the dorsal scapular nerve is up top here coming off of cranial nerve 5. We can see the suprascapular nerve coming off of cranial nerve roots 6 and 5. So it's coming out here, innervating here and here. We can see the axillary nerve coming down in this region. This is going to be our, oh, I wish I had my picture all the way open. I'll get this open so we have our little image. And then we don't have an image of our accessory nerve, but we already know this is our cranial nerve 11. Okay. Oh, maybe I have it here. Accessory nerve. There we go. We can see accessory nerve here. Important kind of groupings again, muscles on the scapula that help to move the humerus. These are all muscles that are located in the scapula, innervated on the humerus so that they're going to help it move. Obviously, our deltoid is going to be the major one, supraspinatus, infraspinatus, subscapularis, we'll see on the anterior portion. We can't see it in this image. Teres minor, teres major, and then our triceps, our brachii, long head and lateral head. We can see both those here. So all of these are located on the scapula or have some type of attachment point with the scapula and also attached to the humerus to help move the humerus. Speaking of which, our deltoid. So if we look at our deltoid, we can think about its attachment points as the deltoid clasps. So it attaches to the clavicle, the acromion, and the spinous process. So spinous process of our scapula, the acromion up top here, and then our clavicle we can see over here. So those are going to be its proximal attachment points. And then it's going to insert on our deltoid tuberosity. It allows our humerus to have extension and flexion, abduction when all three parts are working, and medial and lateral rotation. And our innervation point is our axillary nerve. It's important because depending on which portion is engaged, it's going to have different actions. So the deltoid is a very versatile muscle. Looking at this axillary nerve innervating the deltoid and teres minor, it passes through another space, the quadrangular space, which is located between the teres major and minor, and the long head of the triceps and the humerus. And so we can see the axillary nerve kind of coming out here and then moving out through here. So our axillary nerve traveling across this region. You can have a clinical condition called quadrilateral space syndrome, where you have compression of your axillary nerve and the posterior humeral circumflex artery as they move through this space. And obviously that will decrease our innervation and it'll decrease our blood supply and blood flow. I don't know if I have a great picture of the actual compression, but you can see the axillary nerve coming through here. Can I see the artery? I don't know if I can see the artery in this picture. Maybe not in this picture. That's okay. All right, my favorite grouping, our sits muscles. This is our rotator cuff muscles, another great grouping for a board's question. So memorizing what the muscles are that are going to innervate and support the rotator cuff would be helpful. So we have our supraspinatus, our infraspinatus, our teres minor, and our subscapularis. Those are our sits muscles. If we are looking at kind of action and innervation, we can see that our supraspinatus and our infraspinatus are both going to be innervated by the suprascapular nerve. Our teres minor is innervated by the axillary nerve with our deltoid, and our subscapularis is innervated by the upper and lower subscapular nerves. So that one is at least named or innervated by the one it's named by, same as this. Infraspinatus is the one we have to remember because it's the suprascapular nerve, and teres minor is the axillary nerve shared with the deltoid. We can see that all of their jobs are going to be focusing on our humerus. So we have abduction for our supraspinatus, which is on top here. We have lateral rotation for teres minor and for infraspinatus. And then we have medial rotation for our subscapularis, which is located on the anterior portion of our scapula, attached here to our humerus. The sits muscles, again, like clockwise, supraspinatus, infraspinatus, teres minor, subscapularis. They're all going to blend the tendons with the glenohumeral joint capsule, providing reinforcement. And so, again, you can kind of remember they have to sit out for the rest of the game, and they're sent to the minor leagues, remembering it's teres minor, not teres major. I like this little picture. It kind of gives you some indication of what's going on. The suprascapular nerve innervates the supraspinatus and infraspinatus. It originates from our upper trunk of our brachial plexus, passing through the suprascapular foramen, and it then will pass through the spinoglenoid notch to innervate the infraspinatus. This is the classic mnemonic of Army over and Navy under the bridge. So you can remember kind of who's going through where to get to what. And if we follow it along, suprascapular nerve and artery here, there's our suprascapular notch and ligament here. And so this is kind of the second region that has to get through. And then it's going underneath to get to the infraspinatus. I don't think I have a beautiful, oh yeah, the spinoglenoid notch. There's our spinoglenoid notch to get to the infraspinatus, and our suprascapular notch to get to the supraspinatus. Great. Two majors and a lady. Our teres major. Teres major is going to adduct, so add together, medially rotate and extend our humerus. So adduction, medial rotation and extension, arm behind your back. And it's innervated by our lower subscapular nerve, which is a branch off of our axillary nerve. So moving into our arteries, we looked at our venous structures, we've looked at some muscles, we've looked at some nerves. I want to now focus on our arterial structures of the upper extremity. So we can kind of follow along a few of them. Down at the bottom, we have our digital arteries, which are going to be the ones that go to our digits. We have our deep and superficial palmar arches here. So deep palmar arch and superficial palmar arch. And then we have our ulnar artery and our radial artery. The radial artery is the classic pulse, but we've taken pulses for both. We know that the radial artery is going to be on the side of the thumb. The ulnar artery is going to be on the side of our pinky, or medial versus lateral. And then we can move up here. We can join together and see that our brachial artery is located here in our upper extremity. Brachial artery will extend down from our teres major. It'll bifurcate into those radial and ulnar arteries. And then up top even further, let me see if I can get exactly a good point. Here we go. Is our axillary artery. This is from like the lateral part of first rib to the edge of teres major, where we then split into the brachial. And then all the way up, its source is going to be our subclavian, which is all the way up here, subclavian artery, which is going to be the source off of our big major arterial structures. And it's going to flow through our anterior and middle scalenes. So if we flowed from the top down, we could say we go from subclavian to axillary to brachial. Then we're going to branch into our radial and ulnar. And then from here, we get into arches and then our digital arteries. That would be our flow from essentially up top, superior, or proximal to inferior or distal. So if we look at then our axillary artery, kind of, again, this is showing coming off of the arch of the aorta, which we will follow along here. We have our subclavian, and then moving into our axillary artery, and then moving down into our brachial artery, and then it'll split into our ulnar and radial arteries. But at the lateral border of the first rib. That's when we'll see this beginning, the start, inferior to the border of the teres minor. There's three parts it can break into relative to the pectoralis minor, reflecting its three branches. The first portion gives rise to one branch, which is the superior thoracic artery. The second part is posterior to our pec minor and has two branches, the thoracoacromial artery and lateral thoracic. And then the third part has three branches, subscapular artery, which is the largest branch, that will move into the anterior and posterior circumflex humeral arteries. And you can follow along all these different arterial branching points. Again, I would memorize this first, and then if you're feeling like, oh, I've got this, then learn the sub-branch points of our axillary artery, first, second, and third part. And I have like a little self-quiz that you could practice if you'd like. Okay. Brachial, axillary, subclavian, and then our actual brachiocephalic trunk that's coming off of our arch of the aorta. All right. Branches from our subclavian and axillary arteries will anastomose around the scapula. And we can see then we'll have our dorsal scapular, our suprascapular, and our circumflex scapular, as well as our transverse cervical artery. Why do we care? If the axillary artery is occluded, blood is shunted from subclavian artery to the distal axillary artery via reverse flow, and it'll get to the circumflex and subscapular arteries to try to do essentially like flow around wherever was obstructed. So our collateral circulation around the scapula, which is helpful. This would be the third tier of yield for the arterial structures. Our deep veins, we talked about superficial veins, but deep veins are important too. Just think of them being paired with the major arteries. There's a radial, there's an ulnar, there's a brachial, etc. But there's alternate courses essentially for venous return to the heart, and it's also used for thermoregulations. We have these like venous structures surrounding by our artery to stay warm and also to help hijack that contraction point to move blood back to the heart. A few kind of pieces about elbow joint ligaments. If there's another ligamentous area that's asked about, it's going to be elbow joints. We have our ulnar collateral, which is our triangular shaped ligament with upper and lower bands. The ulnar nerve passes between the bands, posterior to the medial epicondyle, our funny bone. Our radial collateral ligaments attached to the annular ligament. And the annular ligament, we remember, is almost like a sling. So our annular ligament of the radius is like a sling circling around the head of the radius to create that proximal radial ulnar joint. Arterial supplies anastomoses of the arteries around the elbow joint. So our radial ulnar feeding together into the brachial. And innervation is musculocutaneous, radial, and ulnar nerve. So we have innervation from all three. And then you can get a good picture here of this annular ligament, permitting that rotation. The interosseous ligament here is linking the bones together, and it's giving us a pivot type synovial joint, allowing for supination and pronation. Okay. So these are the muscles of the arm. I'm actually going to skip this portion. I think I'm going to go into a couple kind of high yield pieces here. I'm just looking through to make sure we touch on a few of them, but I have images and just your AIONs for everything, just so you have some connection patterns. Okay, great. Perfect. We're doing good. All right. And then we'll take a break here in about 5-ish minutes. So of the forearm muscles, there's 3 flexors that are innervated by our musculocutaneous nerve and 1 extensor supplied by our radial nerve. All extensors and supinators are innervated by the radial nerve. So everything that's extending or supinating, think radial nerve. All words with pronator are innervated by the median nerve. That means that some have 2 innervations, and that's okay. So our pronators, median nerve, our extensors and supinators, radial nerve. And then the flexors are the musculocutaneous nerve. So these are our arm muscles that are crossing over from our humerus to crossing over that elbow joint. Our biceps brachii, it's going to do flexion and supination, and musculocutaneous is going to be the innervation. The brachialis muscle is interesting because it does also cross over this border. Oh, are you there?
We got it now. We just weren't seeing your screen. Thank you.
Oh, okay. Can you see it now?
Yep.
Okay. The muscocutaneous is also moving from our humerus to our forearm, or the brachialis, and it's innervated by our muscocutaneous nerve. Of the three muscles, this is the only pure flexor. So if asked who does the most force of flexion, it's actually your brachialis muscle because it's the only action that it does. The coracobrachialis is, we can see this image right here, coracobrachialis coming off of the coracoid process. It's innervated also by the musculocutaneous nerve, and it's flexing and adducting the arm. And our musculocutaneous nerve, if we remember, comes from our lateral cord, goes into the muscle, and then moves between the biceps and brachialis. So is anterior compartment. Posterior compartment, we have our triceps brachii. It's innervated by our radial nerve, and it's going to extend the arm and extend the forearm. We also, if we look at the radial nerve and say, like, what is kind of the things that it's doing, where is it branching from? It comes off of our posterior cord, passes between our lateral and medial heads of the triceps, and innervates all three heads of the triceps. If we remember kind of fracture-wise what can be affected, we remember arm. So our axillary, our radial, and our median. If we have a fracture at the head of the humerus, the axillary nerve is the one that's likely to be affected. If we have a fracture mid-shaft of the humerus, it's the radial nerve. And we have a fracture at the supracondylar region, it's likely going to be the median nerve. NPLEX loves asking about broken bones and what nerves are affected or what muscles are affected. So remember, if you have a fracture of your humerus, remember arm, axillary, radial, median. Okay. The structures of the fossa here, I am going to move past because you can just kind of look at here. There is this acronym of Bambi to kind of help you remember who's who and in what order. But I want to get to our intermediate layer. Our intermediate layer, we can see these are going to be our flexors. So flexor digitorum superficialis first, with our median nerve flexing our fingers. Our deep layer, we have our flexor digitorum profundus, our flexor pollicis longus, and our pronator quadratus. We can see insertion on the distal phalanges, median nerve to radial half, ulnar nerve to ulnar half. So if we're looking at our flexor digitorum profundus, the median nerve will be on our radial side, and then the ulnar nerve on the ulnar side for innervation. So it gets 2 innervation points. Flexor pollicis longus, moving over onto this radial side, just gets the median nerve, and pronator quadratus, we can see this here to here, is going to be median nerve as well. This pronator quadratus is keeping our radius and ulna together, especially in a fouche injury, a fall on an outstretched hand injury. So that's a good, nice, good boards question or pathology kind of component. Looking at our extensor muscles of the forearm, the posterior group, we have 3 functional groups, muscles that extend abduct or adduct the hand at the wrist. And I have those listed here. Muscles that extend the medial 4 digits, and muscles that extend or abduct the thumb. So putting them in these groupings or categories as you're learning and practicing and doing flashcards, I think is the most kind of key important piece here that you could do. Our superficial layer, we can see the supracondylar ridge of the humerus is kind of our origin. Tendons insert on our metacarpals and phalanges. The deep layer, the origin is our radius, ulna, and interosseous membrane, and they're inserting on the radius, distal phalanges, or the bones of the thumb. Our brachioradialis is going to be innervated by our radial nerve, and it's providing flexion of the elbow and half pronation. Our extensor carpi radialis longus and brevis. So our extensor carpi radialis longus and brevis, look at it here and here. Radial nerve innervation, extension and radially deviating our wrist towards the radial side. Extensors digitorum and digiti minimi, again, radial nerve, extension of fingers. Extensor carpi ulnaris, radial nerve, extension of wrist and ulnar deviation. Getting a pattern here, right? Our deep layer, we have our supinator located right here and here. And then our abductor pollicis longus, I don't have that picture in this one. I believe it's here. I just can't see. It's too small. We can see, this just has origin and insertion. I think I have, there we go. So our deep layer group, extensor pollicis longus, extensor pollicis brevis, extensor indicis, radial nerve innervating all of the muscles of the posterior forearm, the whole meal deal. What's our ulnar nerve doing then? It's innervating our flexor carpi ulnaris. It's innervating half of the flexor digitorum profundus, and it's going to become quite superficial at the wrist region. Brachial artery we've looked at. This is our big blood pressure measuring. And then superficial palmar arch. The only reason I have this piece is because we can see that it's formed primarily by our ulnar artery as it comes into the palm through our tunnel aguillon. And it's going to anastomoses here with our radial artery. So we can see superficial palmar arch has these anastomosis pieces from the radial and the ulnar artery, which is why it is unique and important. Not going to talk too much about the muscles of the hand, but they are here. But the last piece I wanted to mention is just our carpal tunnel. So within the carpal tunnel, we have structures median nerve, two tendons, flexors digitorum superficialis and profundus, as well as the flexor pollicis longus. These are structures not in the tunnel, so don't get tricked by NPLEX trying to convince you that there's arterial flow, ulnar nerves, or other muscles. These are your structures within. These structures are outside. If you have compression of your or carpal tunnel syndrome, you're going to see cutaneous sensory loss on the median nerve side. So this innervation point of the hand here, eventually thenar wasting because these muscles aren't getting innervation support. And your first and second lumbricoles are going to become weak and atrophic. Again, showing overall what the ulnar nerve innervates. And then talking about our ulnar and radial arteries. Great. All right, I know we fly through these, but that's how a lot of this anatomy is. That's why I say highlight the slides that have large groupings of content in them. And those are gonna be your study slides where you're gonna work on labeling as practice. And you're gonna be working on not just looking at the pictures, but reading the words and associating them with an image in your head or an image that you're drawing out. So this is gonna be your best high yield way to study this content. But these are kind of the most high yield components for upper extremity, specifically the arteries and the innervations. Okay. So what we're going to do now is we'll take a 10-minute break. We'll come back at 4 after. So at 10:04, we're going to go through our lower extremity. Lower extremity is going to feel kind of similar. I'm going to lean into, again, vascularity, innervation. They're just looking at bigger structures. And then after this next hour, we'll be done with our MSK component. We'll be leaning into anatomy of certain organ systems, moving into the cardiovascular system and actually talking about that aortic arch and how things are branching off of it. So that will be kind of where we're going before lunchtime. So let's come back at 10:04. I'll keep the Zoom link going. I'm going to stop the recording and then I'll turn off camera and mic and then I'll come back and we'll get started in about 10 minutes.